Hello and welcome to my channel. In this channel, we explain various nursing concepts in a simple form for a better and easy understanding. These videos could be used by both LPN and RN students as well as nurses who are trying to refresh their basic concepts. My name is Nasmosh. So in this video, we're going to continue talking about our burns. And with our burns, we're going to talk about let's continue talking about the fluid shift. The initial fluid shift. With this burn patients, of course, we're going to have fluid shift, right? And in our first 24 hours after injury, the initial fluid shift, we're going to have elevated hematocrit and hemoglobin levels due to fluid shift into the interstitial spacing and fluid loss. We're going to also have a decrease in sodium levels due to third spacing, as well as potassium. Remember, potassium is in the cell, and if it burns, it explodes and the potassium goes to the blood. Elevated potassium, sodium and potassium pump disruption, red blood cell hemolysis, which is the bursting, and tissue destruction, and fluid mobilization. This is actually after 48 to 72 hours after injuries. This is how the fluid shift now becomes. They will have a decreased hematocrit and hemoglobin levels due to interstitial back into the vascular fluid. And then the sodium remains decreased, and we'll have an increased potassium due to renal loss and fluid movement into the cells. For this patient, we'll also monitor the white blood cell count. The initial increase, then there will be a decrease with a shift to the left. They'll also have some elevated glucose due to the stress response. Our ABGs will show slight hypoxemia as well as metabolic acidosis. This patient will have a decreased total protein and albumin levels due to fluid loss. Remember, albumin is considered a volume expander. Okay, so some nursing care that we'll give for this patient. Remember, always ABC. I will maintain a patent airway, ventilation, and will always provide humidification oxygen as prescribed. Most likely tent if the patient has a facial burn, because imagine putting a nasal cannula on this patient. It will get stuck on that skin, right? It's raw skin. Monitor the vital signs. We'll always monitor the cardiac output and administer IV fluid replacement by the Parkland formula. Remember, half of the required replacement formula is administered during the first 8 hours. But remember to remove any fluid that would administered during transportation, right? And then the remaining half is administered throughout. After the 8 hours, it will be administered in a duration of 16 hours. All right. Maintain a urine output of between 30 to 50 ml for burn patients, right? We need them to have that renal function, because if you're not having a renal function, then they'll end up with what? Fluid overload. We'll monitor for shock, hypovolemia, of course. They got fried, they got burnt, they had a lot of loss. We need to make sure we are replacing that fluid volume instead, not to send this patient into a hypovolemic shock. Pain management is key. Remember, whatever the patient says the pain is, that's what the pain is. It's not what you think it is. There's nutrition. We have to know with our burn patients, especially large burns, they will have they'll be in a hypermetabolic state and can exceed 5,000 calories per day. So we need to give them that calorie, right? Their body is on overdrive. We need to replace those calories for efficient body healing. And we need to give them protein intake, a high protein intake to prevent tissue breakdown and promote healing. And TPN is often used, and always remember TPN precautions, right? Check our GI videos. And we promote mobility, restoration, and provide psychological support to both the patient as well as the family members taking care of these patients. Okay, some medications that we normally see given to these patients involve our antimicrobial creams, and it could be silver nitrate, bactrin, silver sulfadides, okay, so a pain medication, some opioids. They'll have a PCA pump and some IV start meds, if PRN, if they need it. Treatment, of course, they have wound care, or they could have biological skin coverings or permanent skin coverings, okay. And the method of treating this burns. So it could be either an open exposure and a closed exposure methods. We could have the topical antimicrobials and the biological dressing and the tissue grafting. So let's get into detail about these treatments, right? So open exposure method, this involves like it's open, it's allowed for draining of the band, right, the exudate, the byproducts, and also it's easy to visualize and assess for the skin. It's open. You can see it, the byproducts are, you can drain out, and you can easily assess it and treat it. And they normally use topical therapy, the topical meds, and it's easy for range and motion because it's not stiffened. And the disadvantage for this, it increases pain. It's open, right? There's an increase in pain and heat loss because the epidermis mostly is damaged and the thermoregulation is not there, and also it's difficult to manage hand and feet burns if they are open. Closed method of treatment. With closed method of treatment, it involves gauze dressing wrapped from distal to proximal. We always wrap it from distal to proximal. We need to aid in that blood circulation. With this, there will be a decreased heat and fluid loss. Of course, we've covered it. And the disadvantage of this is mostly mobility, which could cause contractions. And wound assessments, it's normally difficult, and it's only done during the dress changes. You can only see it when you're taking the dress changes. And if the dressing is every 2 days, you really don't know what's going under there until the 2-day you take it out, okay? Topical treatment. With topical creams, we just apply it topically to prevent infection and promote wound healing. So it's like a seal, all right? And then the biological dressing and tissue grafts. So with hemografts or allografts, it's normally human tissue donors, right? People donated. Xenograft is normally animal source, amniotic membrane, and biosynthetic or synthetic transplant films, right? This is like a man-made kind of skin. So patient education for skin care after dressing changes. So we always wear pressure garments 23.5 hours per day to reduce scarring and control swelling. Remember, this patient, their spaces are not, some of the muscle maybe could be burned, some parts of the skin are not intact, so we need to control that swelling. We encourage an increase in protein and calorie for healing, right? And remember, they're in a hypermetabolic state. We need to replace that to prevent tissue breakdown. We encourage regular exercise as per physical therapy. Keep moving to prevent those contractions. We elevate the affected areas for circulation. Make sure that circulation keeps going, because if it doesn't get circulated, that area can die and the patient can end up with an amputation, right? We moisture the skin and avoid sun exposure. Of course, sun it burns, right? So we don't want to add another burn on top of a burn. And itching control, for this, we'll do cold baths or loosen the cotton fiber and remind them not to scratch themselves, because if you scratch, what is going to end? You're going to keep breaking off the healing skin. And that's it for our burn videos. See you in the next one. Thank you for staying with me. I hope you all enjoyed it. And if you have any questions, always leave down below and we will get to it. Thank you for watching. Please like, share, and subscribe to my channel. See you on the next one. Bye.